Hey folks, Scott Weingart here, and this is an EMCrit We. A few days ago, I released the EMCrit episode 411 on the ANDROMEDA-SHOCK-2 trial, an incredibly important trial in sepsis resuscitation, and I promised that today there would be a discussion with the lead investigators, and that's what you're going to hear now. And for folks listening for free, you're going to hear the full episode in its entirety because it's really important and this deserves to be foam. So I'm joined with Dr. Glenn Hernandez, who is a full professor and intensivist at Pontifical Catholic University in Chile. And he is the lead investigator for ANDROMEDA-SHOCK-2 as well as ANDROMEDA-SHOCK-1. And one of his former fellows, now associate professor and intensivist also at the same institution, Eduardo Catan. And I think these folks have now clearly won in my mind as the two folks who I have not yet gone to a bar with in the intensive care world that I would most like to sit around and have a drink. Because these two, in addition to being brilliant researchers and intensivists, are also just people full of a happiness and life. You'll get that flavor in the next 60 minutes. We go in intricate detail to all aspects of ANDROMEDA-SHOCK-2. Even after reading this trial multiple times, I still learned a ton in the course of this conversation, and I think you're really going to love it. So without further ado, let's get right into this EMCrit We. All right. First of all, congratulations on the trial. It's an amazing publication. It had to be a ton of work, so well done, both of you.
It was like an Everest because we built up a sort of informal academic research organization, informal, supported by some universities, but without formal funding or grants.
Since this is audio, I just want to point out that is the voice you've just heard of Glenn Hernandez, and then the other voice on the podcast, aside from mine, Eduardo Catan.
And every center that had wanted to participate had to obtain their own fundings if they needed one, because this was more, many centers, some academic centers in Europe and also in Latin America provided with the human resources to manage the contribution in human resources was great. And of course, we appreciate this. We value this much more than money because it's though, for example, our university gave us $70,000. And with that, we hired the project manager for the whole project. And so it was a teamwork involving hospitals from very different realities. Big hospitals in Latin America, 20 to 30 centers in Europe of high-level university-affiliated hospitals, a couple in Asia. So it was a very heterogeneous, but every people worked very committed to the study.
It also breaks down the dictum that you need to have multi-million-dollar funding to get good RCTs done. Exactly. You've shown people that's an excuse that no longer holds. They have to get off their butt and actually do trials regardless of whether they get huge grants.
Exactly.
I think that's beautiful because let's say it's possible to do this kind of stuff based on collaboration and friendship and this community that's behind the ANDROMEDA-SHOCK-2 trial rather than only with the money or let's say the funds or the grants. So
yeah, that's beautiful.
One of the great results. That's a second layer, let's say a little bit more within the study. Yeah.
Absolutely. All right, let's get into some rapid fire questions and then we'll go with some more philosophical ones towards the end. So first, in terms of patients, there was a large percentage, nearly 50% of the patients had abdominal sepsis as their source, which is not typically what we see in the ED or the medical ICUs. It was very much my experience in a surgical ICU. So do you think that changes the study's focus to a less generalizable pool?
No, I don't think so. In Andromeda 1, the first Andromeda trial, the abdominal sepsis was predominant over pneumonias, but for not such a wider range. It was around 35%. Here it was close to 45, 50. And this is the reason for that. First is that there were at least 30 surgical ICUs run by an anesthesiologist, intensivist in Spain, especially. So this changed the numbers. But essentially, when we compare the results between, informally, it's not in the paper, between surgical versus non-surgical ICUs, origin the results were almost the same. I mean, the unbalance would say that more abdominal sepsis is explained by this, by the strong presence of surgical ICUs in Europe.
And as a matter of just a quote, since 2014, most of our studies, the main cause of sepsis beyond Andromeda-1 has been abdominal. So I think it's gone with us since the early studies.
By the way, to be honest, we love this because abdominal sepsis in general, which is you take care of the source in many cases rapidly. You take out the gallbladder, blah, 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 etc. You wash the peritoneum, etc. Compared to pneumonia, community-acquired pneumonia in the elderly, where you have this translocation of bacteria for several days, more. So it's as a model, we like it because it's more susceptible to rapid intervention. So it's not bad, I think.
I don't want to linger on this point. I said it would be rapid, but I found what you said just so interesting just now. One could argue the opposite as well, right? Because in abdominal sepsis, we do get source control so rapidly. So it's in some ways, an easier sepsis to tackle. We just have to now provide hemodynamic stabilization for a period of time until their innate resources start being mustered. While the more difficult source control, you give antibiotics to a raging pneumonia, you're right, it's a few days before we truly have the source under control. So the harder acid test might be these medical sepsis patients than the abdominal. Does that resonate at all?
Yeah, I think I agree with you, of course. I think we did a very rapid comparison between the two groups, but apparently they were similar, but we will do a formal analysis of this. And maybe it would be nice to publish as a post hoc. By the way, it's interesting because we can do that, of course. And we wanted to publish with the Spanish Society of Anesthesia, which participated in this trial with a strong participation, to look at also at the patient that developed septic shock in the OR and were immediately incorporated in the postoperative early stage. And this is a large amount of patients. This also has been not addressed very in the literature, patients that develop septic shock in the OR formally, with formal definition. So I think we have a lot of sub-studies, post-hocs that we can perform. And this is what you propose is very interesting.
I love that. And it anticipates my next question because the time from meeting inclusion criteria to randomization was 2 hours, which is amazingly impressive. That's fantastic for a study, but it's still 2 hours of maybe the most crucial period in a patient's care. And you can never ask in a study world to get less than that. But in our practice, do you think if this was really done at the point of recognition, there would be a more robust treatment effect?
I think that point, as you mentioned, is quite interesting because this 2 hour time frame, you have to identify, ask for informed consent, and do all the, let's say, logistical aspects of the study. But I think that if we can translate this intervention earlier, I think it could be even better regarding treatment effects. And for the ANDROMEDA-SHOCK-1 trial, we did a post hoc analysis in which we assessed within that trial patients that normalized capillary refill time at 2 hours. And when the resuscitation was stopped in that group compared to lactate, it was a post hoc, but they had even better outcomes. So maybe it's super time sensitive, especially knowing the kinetics of capillary refill time. That CRT, there's studies by Lisa Raya and Hafida Itufela that show that CRT responds up to even 15 minutes after a fluid challenge. So maybe bridging this resuscitation algorithm earlier can even be better. So I think that's good. I hope that the translation to clinical practice yields better outcomes as well.
And maybe people, when they hear about Andromeda-2, they will think that this is an emergency department-based trial like others. And it is not. A percentage of patients, a relevant number, came from the emergency department, but others came from the OR, at least 30 or more % of patients. Others from the step-down units, others from the same. The sources are very different. So we had to make all a emergency call inside the hospitals to call when there were the first signals, etc. So I think I agree with you that 2 hours is very fast.
Yeah, absolutely. No doubt. So if you got these calls from all over the hospital, were they resuscitated in situ or were they brought to the ICU for the resuscitation?
We we brought most patients to ICU.
Yeah.
Let's say there was one center that had an ICU, let's say, service embedded in the emergency room. But
a satellite. They were embedded, yes, but only one. They recruited 140 patients, something like that center. But it's the only case. The other cases, they had to move fast to the ICU. We had protected beds in many of these centers. And the centers, of course, from the OR, they came immediately to the ICU. So after.
There was nice coordination between emergency room teams or step-down units team with the ICUs within these centers. And this was also part of the pre-work we did with its study site.
That's fantastic. All right, let's talk about the logistics of the actual CRT testing. So obviously in a study, you want reproducibility, completely understandable. Microscope slide, a stopwatch. What are you guys doing in your own practice?
For the studies, we use these microscope glass slides, and we press until the ventral part of the index fingers is blanched completely. And then we start with our phones, our mobile phones, a chronometer, and stop at 10 seconds. And then we count the time of refill up to the normal value of 3.7. In normal practice, I recognize that we do it this way. The classic, we press a little bit and then we see just qualitatively, I would say, or semi-quantitative. But for the studies, it was very rigid, the method.
Now, the pushing down on the finger part without the slide makes complete sense. And I'm guilty of this as well, of not using a stopwatch. But my perception of 3 seconds is very altered by my individual, whether I've had my coffee or not, or what have you. So obviously, we're not going to have the microscope slide. Do you think people should be using a stopwatch?
I think we're all carrying our phones, and it's super simple to get the stopwatch. So I think if it's available, it's a let's say better practice. It was just to bring some data into this suggestion. There was a meta-analysis by Matthias Jaguet-Lagres that assessed the predictive capacity of CRT to identify patients at risk of death. The pull-out ratios was around 4, but when performed with a stopwatch and, let's say, better technique, this increased up to 10. Even though it might seem trivial, this could bring better, let's say, yield and less interrated observation on the Mississippis.
Yep, I love it. Love it. What do you guys say in Chile? Do you have a word that you use?
We use the Mississippi sometimes.
Oh, you do? Oh, man. Okay. So let's talk about the diastolic blood pressure push. So the first question is, I did the math last night. I don't think it's possible that if you have a MAP of greater than 65, I don't think you could have a diastolic less than 50 without a pulse pressure greater than 40.
Yeah. Well, let's put this another way. Because when we decided to take the first decision-making, let's say,
the science phase,
we put pulse pressure as low or high. At the beginning, when we started to draw the study, we saw in three levels of pulse pressure, less than 40, 40 to 60, and more than 60, but it was too complicated. So finally, we decided it's arbitrary, a cutoff of 40. And then we said, if this is low, it probably predicts a low BTI or SB, and then you go to fluid response. That is clear. But from the other side, we wanted to act in the diastolic blood pressure for a long time, because we strongly believe a line of physiological thinking that the best predictor or surrogate of arterial vascular tone is diastolic blood pressure. It's not systemic vascular resist and all this. No, it's diastolic blood pressure. And of course, the physiological, let's say, relevance is, of course, coronary perfusion, etc. So we know, and we discussed this a lot, Scott, during the design of the study, that when you have, for example, diastolic blood pressure of 30, profound vasoplegia, in general, it is associated with the hyperdynamic state. So it coexists, a cardiac index of 6 and vasoplegia, blah, blah, blah. This is usually the case. So if you ask us, it is possible to rise diastolic blood pressure without influencing pulse pressure at the same time, or MAP or cardiac index? I'm not sure, because we have to perform more studies about that. But increasing diastolic blood pressure by slightly increasing norepinephrine appears to us as a good research question. So we try to put this. We are not totally happy. We have to be honest here, because we expected better resolution of CRT with that. And when in patients that we performed the test at 23%, which is not bad because it's one in four patients where we performing this DAP augmentation.
Around 20% that normalized CRT.
Normalized CRT. Because here we were very strict in the design of the study. It was CRT normalization, not improvement, as in studies with LAC, normalization. So this was very, let's say, a very, let's say, exigent, very
strict.
We put a high level of cutoff to say normalization. But the whole group of when we performed this DAP augmentation test decreased CRT from 7 to 4.7. So it was an impact over other patients. They did not meet the criterion of normalization. So we think that this deserves further study, especially because, as you said, and we know that when you increase norepinephrine, you not only you increase diastolic blood pressure eventually, but also you influence preload and other hemodynamic variables. And at the end, if you normalize CRT, you can ask yourself, is this because of the increase in tone that improved the coronary perfusion or microcirculatory, or it is about the other hemodynamic? We don't know. But we will perform post-hoc studies to analyze this.
I love that answer, and it answers a bunch of the other questions I had. I was simply talking about the mathematical possibility, and I think you could eliminate that pulse pressure of 40 box because it doesn't serve any purpose, because you can't mathematically be a MAP over 65 and have a diastolic less than 50 with a pulse pressure less than 40.
No, but the arm that goes to the diastolic blood pressure is the one with higher pulse pressure over.
Of course. 40. What I'm saying is that box is irrelevant. You can't, the only way you're not going to already have a diastolic greater than 50 is if your pulse pressure is greater than 40. So that box, I'm just trying to simplify the flow chart. It doesn't do anything. So what you could do is simply say, ensure MAP of 65 and diastolic greater than 50 at that point in the chart, and you'd lose nothing.
You're right. No, absolutely. We agree. Thank you. It's a good suggestion. Yes,
it just popped up in my head last night, and then I checked it by math because I'm like, can you get it?
Yeah.
Okay, so that makes sense, and I think you're right. I think this deserves further study because I found it one of the most intriguing parts of the study was this diastolic push. And is the MAP actually the wrong number in sepsis? So I love that. All right, let's talk fluids. Now, I think everyone was super happy to find that the intervention group wound up having less fluid overall. That was incredibly reassuring and a real mark of this trial going in the direction I think most smart people in sepsis are going. Why only 1,000 mLs in tier 1?
That's a good question. And what we tried to do there was to limit the first, let's say, pass of fluids without doing an echo. So the first two loads, the first two 500, let's say, fluid boluses. After that, you needed an echo. And if the echo was okay, you could continue giving fluids if capillary refill time was abnormal and the patient was fluid responsive. It was just to, let's say, make sure there was no significant right or left cardiac dysfunction, like a safety.
This was 1,000 was the limit for tier 1 intervention.
Yep, absolutely.
Simple, blah, blah, blah. After that, you had to perform an obligatory echo, etc. I can tell you a small anecdote because in the steering committee, there were guys like Daniel De Backer, Antoine Villiers-Baron, you know these guys?
Yes.
Antoine Villiers-Baron is the guru of echo. Blah, blah, blah. When we started drawing the algorithm, I thought he was going to push to perform an echo at baseline for everybody. But he said it's not necessary. Antoine Villiers-Baron, he said, no, because eventually this more, let's say, soft intervention, a couple of fluid boluses, blah, 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 can solve the problem. And then you don't press, especially centers in the medium or low-income countries, to push. You need to perform an echo at the beginning. You put the echo in the transition from tier 1 to tier 2 for those patients, essentially. And this is great because the study by Flowers was published last year from the UK, where in the UK, only 15% of the patients admitted to the ICU, they had an echo in the first hour. So It is not that it's immediately available. So the first decision had to be taken with this hemodynamic phenotyping based on this sign. This is what we saw.
I love it. That makes sense. Why was the fluid given over 30 minutes? Was this from the work out of Africa showing that slower fluid actually is better handled and not causing fluid overload? What's the rationale?
Yeah.
Scott, maybe I can. I don't know. We have not talked about it. But
Let's see if we agree on the answer.
Okay, I love it when there's a little controversy.
When we, in ANDROMEDA-SHOCK-1, we used 530 minutes because this was the standard of care in most of the centers around the world. In the Phoenicia-1 study, the vast majority of people asked about, they gave fluid boluses in 30 minutes. But now it had changed. It had changed for more rapid administration. We discussed this a lot when we were designing the study. We said, because the work from Antonio Messina and all this group, the fluids from the guidelines have been participating in this also. But the people that now are giving fluid more rapidly, the bolus more rapidly, in 15 minutes, blah, blah, blah. But we did not want to change the practice. And so I am not sure if we did. Maybe we should have, but I don't know. This is, I think that...
I was going to say the same. Now practice goes to 4 ml per kilo in 15 minutes.
More rapidly, yeah.
But we were anchored, let's say, into the Phoenicia study and the practice in ANDROMEDA-1.
That makes complete sense. All right. I found a list of fluid responsiveness tests that from a prior study that you folks had done, and Catan was the lead author. Was that the ones that were given to the study participants as well?
We recommended, let's say, different tests according to the individual patient characteristics. Let's say patient was mechanically ventilated or not, had arrhythmias or not, patient, you had, let's say, cardiac output monitors or not. And we tried to hierarchize them. We did a little update from that one that was ANDROMEDA-SHOCK-1. But the idea was to exhaust all the alternatives to test fluid responsiveness in the individual patient. That was our, let's say, our ethos, not use one or another test, but try to, but there, of course, were some patients that it could not be tested, or let's say clinicians did not believe they were reliable enough. So that was part also, we capture it through the protocol deviations.
Okay. And so on the list from ANDROMEDA-SHOCK-1 was IVC collapsibility in spontaneously breathing patients, which I love as a marker of fluid tolerance. I think if you're still collapsing, then you probably could handle the fluid, but it doesn't necessarily mean they're responsive. That was the only one on there that I think was a little less evidence-based. Do you have any idea of which ones people were choosing? Was that tracked?
We have not assessed completely the data, but I know from, let's say, from it was not published, but IVC collapsibility was not used much.
Okay.
Let's say.
That's great.
Yeah, we did not, let's say, recommend it as a...
We had Jean-Louis Teboul in the team and Antoine in the steering committee. And they do not recommend IBC as an example for this. So we were influenced by this. So with that, but we were very pragmatic. People said, try to use the test that you practice in your unit in normal circuit.
That makes sense. One of my listeners, and this just happened yesterday, he found a study saying that if the CRT decreased by 25% with a passive leg raise, that was predictive of a response to fluid loading, which would be amazing because now you have the abnormal CRT, which brings you to that point in the flow chart. You do the passive leg raise, you recheck the CRT, and you're like, oh, it decreased. And you give them the fluid. You don't need a cardiac output monitor. You don't need... So what do you guys think about this? It was a tiny study, but...
It's amazing by Matías Jaguet-Lagres and the Illinois. And I think they've embedded two areas that we usually are looking separately, tissue perfusion and cardiac output. And with their passive leg raising, they identified, let's say, they killed 2 birds in a shot.
Yes.
For this study, we did not recommend it because it changed both the trigger and the target of resuscitation. But if, let's say, for clinical practice, I love it because you can do fluid responsiveness outside of the ICU, basically.
Yes, exactly.
We definitively love the study of Matías Jaguet-Lagres. Every one of my lectures, I present his data because it's so simple and it related to micro circulatory coupling. And then it's also very interesting. I love it.
I would love to see you two or your group reproduce that study on larger scale. That would be
that would be
amazing.
Yeah, exactly. Yeah.
All right. In tier 2, there were safety parameters that would stop you from fluid loading, even if they were fluid responsive still. I couldn't find them anywhere. Do you guys remember off the top of your heads what those safety parameters were?
CVP over 15.
Yeah.
And an increase in CVP more than 5 after a fluid challenge.
Yeah, exactly.
And let's say respiratory, let's say decreasing oxygenation or increasing FiO2. That were like the same as, I think it was carried over from Andromeda 1.
All right, fantastic. All right, let's move on to cardiac dysfunction. This was another one I had to search to find what was actually sent. And I just found the definition of LV systolic as LV fractional area less than 40 plus an aortic VTI less than 14. And then RV failure was RV dilation and a CVP greater than 8. Were those the ones used in the study, or?
These were taken from the ESICM recommendation or guidelines. And this part was written by Antoine Villiers-Raoult. And he said, this is the best we can do because this is what they are doing. This criteria, they have been incorporated in several studies of the French groups, etc. So this is easily to perform. So this is why we use this criteria. We have to tell that this is a strange Scott, because our study, the management of cardiac dysfunction was not part of our study. When the guys put and found one of these criteria to define RV failure or LV dysfunction, they treated them as they used to do. Usually dobutamine in some cases in the RV prone position, decreased PEEP, etc. But at the end, what we said this, very pragmatic. At the end, you treat. At the end, you look at CRT again. And if the CRT has improved, we said, it's responded to the management, but the management, they had to register, but it was not part of the research questions, how to manage this.
That makes complete sense. And that really goes with the pragmatic nature of it. So that's great. The recommendation for LV systolic failure was usually going to be an inotrope. And you folks chose dobutamine for the study. Why that one? And why not something like low dose, inotropic dose epinephrine?
For the dobutamine?
For dobutamine, either for its specific spot in tier 2 or most of the people in the study were using it for LV systolic failure in the cardiac dysfunction as well.
It was very pragmatical because it was the drug that most of the centers were using on one side. And for the tier 2 part of the dobutamine test, we're not only focusing on cardiac output, but there's some evidence that it can increase the microcirculatory blood flow.
By direct effects, by the vasodilatory effect. And this was pushed by Daniel De Backer, for example, who had studies in the past with video microscopy under the tongue, where he found that the physiological studies, of course, with low dose dobutamine, it was an improvement in some variables of microcirculatory flow in doses that did not increase cardiac output. Can I be very honest? Didn't want to add the dobutamine test. I don't like, because even in low doses, you can increase heart rate, blah, blah, blah. So I'm not a fan. Fortunately, it was the last step of the algorithm, and it was used for a very few patients, less than, I don't remember well, 6%?
Let me check the facts.
But
here,
less than 10.
40 patients.
40 patients only. And concerning the treatment of cardiac dysfunction, this is the European view. In Europe, in France, in Spain, they use dobutamine mostly to treat when they found this LV dysfunction. And maybe in the US it's different.
That makes complete sense. And it's lovely to hear that the lead investigator actually had some prejudice against this, unless it was forced your hand to do it.
And I can tell you a confidence, we voted. We were 8 guys. I lost. The majority of the guys said, no, we have to perform a dobutamine test as the last step.
It's a narrow therapeutic index, but we had already done a cardiac ultrasound. There were no signals of hypovolemia. So let's say we tried to make it as safe as possible.
We put a lot of safety criteria to use the test. Heart rate less than that, blah, blah, blah.
Makes complete sense. All right, let's talk about a hard one. So the MAP push to 80 to 85 for the hypertensives.
I can take it.
You can?
Yeah, I want to take it. Okay.
All right. So I'm sure you guys know before I ever mentioned it that subsequent to the study protocoling, probably subsequent to the study's data being collected, we had Optipress come out. And we had a harm signal there. So would it still be in the study if you knew now, what you knew then, what you knew now?
Completely. Because we have data from, let's say, sepsis PAM 65 trial, there were no difference. But Optipress showed that higher mean arterial pressures could bring worse outcomes, right? However, these 3 trials were fixed dose of higher MAPs for a longer period of time. So there was a cumulative exposure to vasopressors and maybe could have driven worse outcomes. However, in this trial, the beauty is that we did it as a test. So the patients had to be previously hypertensive and abnormal capillary refill time. And we tested for 1 hour a higher MAP target. If capillary refill time was normal or normalized, we kept it. And if it not, we went back to the original, let's say, MAP target. And why? Because there are some nice studies, one by Arnaldo Dubin from Argentina in 2009, that showed that the microcirculation, sublingual microcirculation response to an increasing MAP was quite heterogeneous. Some patients improved, some patients decreased, and we showed the same with capillary refill time last year.
We published last year, yeah, with this.
We in Annals of Intensive Care, we did a vasopressor test, and let's say 1/3 of patients improve, 10%.
Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Deteriorated, and let's say, I don't remember the number, it did not move. So what we're trying to do here is to do a test and see and tailor the therapy only those that responded from a perfusion perspective. So I think it's not quite comparable to the other trials that had a fixed, let's say, strategy. And in the worst case scenario, if we saw no response or even deterioration, we could go back.
That makes complete. Oh, go ahead. Go ahead, please.
I think the concept of the vasopressor test, the MAP challenge, is very. I mean, we love the concept because compared to the typical toss a coin, no, this guy, the RCTs, the classic RCTs, high versus low, blah blah blah. No, we now personalize. We say, okay, some patient may improve, some patient may deteriorate based on the physiological studies of what we said before. And the explanation for that one is that the response of the MAP versus the effect of norepinephrine at the precapillary level with the arterioles and the interplay between the increase in MAP and the critical closing pressure, these are microhemodynamic variables that all are mostly are theoretical because it's difficult to assess as besides physiology. But there are many possible explanations why some patients you increase MAP and you improve the microhemodynamic pressures to enter the microcirculation, and others not. And you can distinguish this with a simple test. A simple test, this is why we love it and defend it, because it's a way to personalize also the test. Instead of saying, no, I will go for high blood pressures in all hypertensive patients no, we don't believe it.
And Scott, just to give some numbers, from the 720 patients, only 62 arrived to the MAP test. And from these 62 patients, 56% of them improved CRT, normalized CRT. So in the other 40%, we went back. But in these 35 patients that normalized, we went with a higher MAP.
So let me, what you said from both of you, well taken, and I understand that viewpoint. This was a 6-hour study, but translationally, it has implications on the rest of that patient's ICU care. And if we just take this as they were a responder to that 80 to 85, without any additional advice, the patient's probably going to be for the next 4 days at 80 to 85. I wonder if upon translation, we say, all right, their CRT normalized, we'll leave them at the 80 to 85 until some point that they're getting better. And then we'll repeat a test of, okay, the CRT's good. Let's bring them back to a MAP of 65 and see, did the CRT worsen? And then you'd have the ability to have a short-term intervention for microcirculatory perfusion, but then pull back and not leave, because it could be there is a definite benefit during this inflammatory phase. And then the harm comes later on in the patient when they don't need it. And that balance led to optopress being negative. So what do you folks think about that? Because they can't see on the listening the thumbs up.
Yeah,
So tell
I
me
think
some
that's
verbal response.
Great idea.
Very nice, let's say, explanation on this.
Yeah, of course.
And we can explore it. I love this conversation. We're having a lot of post hoc ideas.
I have many ideas after this in my mind, so it's great.
It's a pleasure to be having this discussion. It's fantastic. All right, let's talk results. Now, you folks in your power calculation projected a 6% mortality separation, and there was none. What do you think made for that discrepancy?
There are many explanations. Let's say the study was not powered to find only a mortality difference. When we did the original sample size calculation, then we would have taken 5,000 patients, whatnot. So was designed and for the 1,500 included the 3 hierarchical outcomes, let's say. Second, why we had a lower mortality rate than our expected, let's say. I think there are many reasons. First, processes of care in septic patients have improved considerably since, let's say, ANDROMEDA-1 was 10 years ago.
Yeah. ANDROMEDA-1, the mean was 39 or something, 30, 20, 38.
Also, we increased our, let's say, external validity. The study was done more in resource constraint setting. Latin America, now we included centers in Europe and Asia as well, and in North America. And third, I think that this early identification of patients also, even though they were randomized to either group, I think also helped or not, depends on how you see it, in this, let's say, better provision of better care in both groups anyway.
We were not surprised, to be honest, when we found that the mortality was similar between groups. We were not surprised by that one. It's difficult to demonstrate a difference in mortality nowadays, but we were surprised by the number, 27 versus 26. It's very low. Indeed, it's like the average of mortalities in the 3 studies, the PROCESS, ARISE, and PROES, but we don't know. There was a heterogeneity also. The European countries, in Spain, for example, 30 centers, they had a mortality of 21, 22%. In Mexico, which provided a large amount of patients, in public hospitals overcrowded, they had a mortality of 32 approximately. So the average was 27, but it was not homogeneous. But the mortality was very close between both groups. Of course, I mean, it was evident. Finally, the strongest reason why we choose the composite outcome went for that one, besides the fact that people forget that the cardiologists have used this composite outcome for a long period, clopidogrel, everything that we are standard have been tested in composite outcome, and this is hierarchical also. So because when we thought, okay, it's very difficult to get a mortality difference, actually, because we calculated the power and then we had to choose something like 5,000 patients per branch, and it was without funding, etc. It was very complex. So we said, okay, let's go for a composite outcome. And why we were very interested in looking at the duration of organ support, because probably from the ANDROMEDA-1 study, that the mortality almost reached a statistical significance. You remember, 0.6. And a Bayesian post hoc that was positive, blah, blah, we know that. But the strongest signal in predefined secondary outcome was the SOFA-related organ dysfunction. More rapid resolution, lower mortality in patients that started the study with SOFA less than 10, etc., etc. So we said, when we discussed this for months, it was not an opportunistic decision. It was a priori, of course. We said, we have to incorporate some primary outcome that, redundant, but incorporates some way the organ dysfunction. And not SOFA, because we think that SOFA is some. And by the way, there was the SOFA2 group evolving. No, SOFA no. Duration of organ support. And maybe you agree with us that even if it may have some confounders and some subjectivity, because, of course, the decision to extubate a patient depends on the willingness of the clinician, blah, 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 etc. We know that. But it's considered by most as the second most important patient-centered outcome in the ICU, duration of organ support. We are speaking about relevant things, intubation, duration. So we said we have to incorporate. And then we started to speak with the expert in statistics, the people from Sao Paulo. They had a lot of experience with the win ratio. He said a good solution would be the win ratio because it's composite, but it's not the composite like the older cardiologic studies. They mix up apples with oranges. Admission for heart failure versus death. No, it's hierarchical. So we were seduced by this concept. Mortality first, organ dysfunction, then we got out of the third. We had to think, okay, why don't we put as a third sort of epidemiologic sense, like hospital stay? We were not very convinced that this was a good idea. We discussed this also a lot, but finally we came up with this. There have been some criticism. I have read it in the Twitter, X, etc. People say, no, when you perform win ratio, you have to have 3 similar relevant outcome. But if you have 3 similar, why do you do it hierarchical? Because so finally, we took this decision. But this was honestly, this were the reason.
That makes complete sense. And I was made happy that it was the organ support that was the major driver and not the length of stay. That would have been problematical.
If it was the duration of hospital stay, we would kill us.
Exactly.
Because we work so much, we no.
Now, my fear is if a lot of critical care researchers see this, and this is obviously an easier way to power a study, we could see more people going in this direction. Do you think that would be a problem from diverging from more primary outcomes?
I don't think it would be a problem per se, even unless you try to abuse or use it wrongly. In fact, in cardiology trials and cardiac TAVI trials, there's been a lot of shift to win ratio, but I think we still need to deliver the message to the bedside clinician because it's a little bit tougher to interpret. What is a win? What is 300,000 wins? So I think we need to bring it to the community in a way that it makes sense and in a way that it's not, as Glenn mentioned, an opportunistic decision, rather a design phase decision from the beginning of the trial.
I have a personal opinion here. I have not discussed this with the steering committee or Eduardo even. Is that if I had to design a new trial now, after Andromeda 1 and 2, etc., I would eventually go for duration of organ support 3 days as the first hierarchical outcome, and maybe add another one, which is the long-term 6 months after the quality of life. I would do it differently. Probably mortality, I will be downgrade mortality because it's so difficult to impact mortality. And it's so easy to rule out or discard an intervention like this, physiological based with simple tools, because it did not influence mortality. It's the same, probably you will comment the study with the invasive versus non-invasive arterial blood pressure monitoring that was presented in the same meeting. Mortality, so I would love to. And I don't think, if I can only guess, if we had selected as the primary outcome organ support or organ support 3 days, probably it would have been positive. I don't know. But eventually, and for the future, I will go for this outcome. Just trying to make it the best, the more standardized as possible, more objective, the decision to extubate, the decision to start or stop renal replacement therapy. Try to homogenize. With this knowledge, probably the design of a future Andromeda 3, let's say, we would select this more refined way to evaluate organ support.
I don't know. My statistical power is not such that I could figure out a fragility index for this form of statistical design. But it feels like it would be a fragile result. We have a p-value of 0.04, 1.16 with the hierarchical statistical analysis. Do you think this is a fragile study result, that it was by chance that we had the positive result rather than a true signal?
No. I think the results, the most important finding besides the outcomes involved in the win ratio is the fact, and this is very important, the fact that the intervention group normalized CRT at a much higher speed and velocity than the control group. The CRT decreased from 3.7, I think, to 2.6, and the other group remained abnormal it was normalization in 85 versus 60 something in the other group. And this For us, we have been involved in studies starting with physiology, almost 2 decades about this. And we strongly believe now, we have worked with lactate a lot, with microcirculation of the tongue, etc., etc. We strongly believe, and performed, by the way, several of physiological studies now, trying to understand what CRT is, because this is a joke that I make in my lecture. For example, I said, always I start, when we designed and conducted Andromeda-1, we had no clue what a CRT was. There was a test, but now we know that it has to do strongly with microvascular activity, skin blood flow, and other variables. So I think we know much more. I think this is a very relevant data, the rapid decrease, faster decrease in CRT, normalization of CRT, because this means, for us, resolution of hypoperfusion, by faster resolution of hypoperfusion. And this is the relevant aspect, because by which means, by less fluids, a little bit, by the diastolic blood pressure, maybe in a little bit of patient, maybe by blah, blah, blah. These interventions are a package of things physiologically based that finally led to a more faster resolution of hypoperfusion. And this probably has to do with the results. No? Do you agree with?
I agree. And just to complement, I think there's a lot of signals that show a trend, let's say a signal in the same direction. There's a normalization of capillary refill time, 20% more. There's a faster decrease in SOFA score from day 7. That's in one of the tables. Also, the individual life supports, duration of vasopressor, duration of mechanical ventilation, and duration of renal replacement were significant in the tertiary outcomes. And we also...
There were CVP also at 6 hours.
So I think that it builds upon a lot of signals that point in the same way. So even though, as you mentioned, the p-value was 0.04, from my perspective, the results are quite robust. And
if we made an hypothetical play here, we zoom the results of Andromeda-1 and Andromeda-2, 2,000 patients approximately between them both. CRT is the big winner, because in Andromeda-1, it some way was superior to lactate in several aspects. And now, the main driver of the results is probably the more faster normalization of CRT. So I think this, in 2,000 patients, it validates CRT as a target and as a monitor and a target. The Surviving Sensitive campaign recognized this, recommended, blah, blah, blah. But I think it's very important also for the concept of this simple test, more than saying this is and we specifically, we stated that we had a very hot weekend in the social media defending, and I mean, 75% of the people loved the study, and there were 25 that were very critical, especially in the US. But we depended, I said, for CRT, it's a very good, let's say, now we can speak with much more confidence about CRT as a target. And I don't think, and we don't think, Scott, by any means, absolutely, that this is the ultimate algorithm for septic shock resuscitation. No. We brought ideas to disrupt this one-size-fits-all, to disrupt all this toss a coin, and half of the patient go to high, and then to low, and then at 28 days you look at mortality. No, we don't like that way of studying. We try to personalize. It's the first effort to try to personalize, but not with complex, sophisticated technologies, but just pulse pressure, diastolic, blah, 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 things that can be done. And we are very proud about the fact that the violation and deviation were less than 15%, and which is not, but it's also a merit because we spent a lot of time in training the center with videos. We have a YouTube channel with all this intervention explained a lot. There was you made a sort of
PDF file with everything step by step, how to do the
manual of operation was very active, etc., etc. And we also had a very strong data quality monitoring, because the 6 hour, I don't know if you read the electronic supplementary material about the control tower, because there was people in Colombia, in Cali, Professor Gustavo Spina, they had a group of 2 medical doctors that looked at when the people entered the patient in the intervention group, they have to upload the data in less than 48 hours. And they looked at potential violation, deviation, and we know every patient of the 700, every patient. And in E-table 2, the trajectory of each patient is drawn. So we know, and then we get reinforcement, feedback. O sea, there is a lot of work behind. It's not that, so maybe in 10 years more, nothing is left from this. But people at least know that it is feasible to apply this physiological, and it apparently it's associated with some mild but significant improvement in some patient-centered lab.
I love all that. And I'm just playing devil's advocate here as I push back against it. Some people have suggested that some of the benefits would come from simply these patients being checked far more frequently, at least once an hour, and then in the patients who actually had abnormal CRT, probably more frequently than that. What do you have to say about that? That was, I think, my conjecture for why there was a signal in early goal-directed therapy was not the intervention, but the fact that someone was at the bedside for 6 hours in one group and not in the other. So what do you think?
This is an interesting, let's say, comment, and we discussed it when we were writing the manuscript and all. But what are the counterfactuals that you could say patients in the control group also received a lot of care? For example, there was a higher use of bedside echo in the control group, where almost the use of fluid responsiveness testing was also, let's say, let me check the numbers, around 60% of patients also received fluid responsiveness testing in the control group. We had hourly checks in the CRF for these patients, and fluids were even more administered. So there was not like an inadequate treatment in the usual care group. And what's interesting, I think, from my perspective, is that the cap refill time group was more targeted. So, for example, fluid responsiveness was tested around 65% in patients with normal and abnormal cap refill time in the usual care group. But in those within the intervention protocol, 95% of the abnormal cap refill time had a fluid responsiveness check. The same thing with fluids. Fluids were given less overall, but those patients with normal cap refill time almost received less than 200 cc's. So I don't.
They were more tailored, more focused.
Yeah, that's what I wanted to say. I think it's not that the other group is not cared for or less cared for, but I think the CRT, the intervention group, was more tailored. And also, just the last thing, 65% of patients normalized cap refill time with tier 1 intervention. So let's say the rest of the protocol, they were just doing the hourly check in both.
Can I add something just very short? That when I was a young resident, I met a master, Professor Max Harry White, when he went to Chile, and I heard him that when you have a shock situation, you have to take a seat and a chair and sit at the side of the patient for 24 hours, whatever it takes, until you are satisfied that the patient is reperfused. This is my master, the guy that I admire more, Max Harry White. And since he said this, when I was young and a post-residency, I started to practice in this. And I remember when my first shifts, night shift, I spent all the night at the side of the patient. So when they tell me, maybe this is the result of more frequent clinical assessment, we cannot rule out, of course, that this is some part of the truth. And if it is, welcome, because it's back to the patient. Because I see so many of young people, now I am old, I see the young resident, they are technological guys, no? They are with their machines, tablets, and they blah, 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 they calculate signals online, blah, blah, blah. But to oblige you to go to the side of the patient, I think it's wonderful. It's wonderful.
I couldn't agree more, and I couldn't agree more with Max Harry Weil as someone truly amazing. I want to be cognizant of your time. Do you folks have time for 2 more questions?
Yes, of course.
Okay.
We'll
fantastic. Thank you. The other side of what we just spoke about is you trained the entire participants in both arms. Do you think there was dilution in the control group? And that might be a reason they weren't as separated, is you love, after you learn this stuff, the ease, the utility of it. Do you think a lot of people in the control group were getting the same care as in the intervention group?
Yeah, exactly. In our meetings because we were the central coordinators with Eduardo and Gustavo, we spent every day of our lives during the last 3 years with this project. But the other members of the steering committee, Daniel De Backer, Antoine Villaverón, for example, their biggest fear was the contamination of the control group with the intervention. And they said, this is my worst fear, that at the end, we don't find gradient of interventions between both groups, and this will dilute the signal, etc., etc., etc. And we said, there are ways to assess this if it is true. For example, we had no time to do this because we worked the last couple of months, 3 months, like mad dogs, because we had to catch the hot topics with the JAMA publication, and we have no time to we are not going to perform the analysis. For example, let's say take the 10 biggest recruiters and look what happened in the first period, 6 months, versus the last 6 months of 2 years of recruitment. And I'm pretty sure that the gradient of differences in the differences will shorten, will be narrower in the last, because there is, of course, a training, a contamination. So maybe this may have diluted a more stronger effect. This was we feared most.
But reading it positively, let's say, we still found the difference, even though contamination was plausible.
Absolutely. And I can't wait to read that, because I think it's going to go exactly how you said.
Yeah.
And then that is even more supportive of these interventions. All right. So that brings us to the last question, which is, how should people be translating this? You've already alluded to that following the exact protocol is not the thing you really want to get across. That, first of all, the utility of CRT, if anything, is the most enormous message to personalize care. And now it opens up a whole range of things where it's, on this individual patient, I think I'm going to start with this because something in my clinical gestalt says that this is what they're going to respond to. And you could test it and see if it has the effect you wanted on CRT. So is this more of a conceptual idea, or do you anticipate people should be rigorously following the protocol?
I think there are two sides of this coin. Let's say clinical practice. I think for the clinical practice, for the day-to-day clinician, I think the best would be to bring these two concepts. Let's use cap refill time as a target for resuscitation, or a surrogate for tissue perfusion. On the other side, it's relevant to personalized care. If a patient, let's not go for one size fits all, but let's try to identify what's happening to our patient and let's try to give care. Maybe the protocol in the next 10, 15 years changes a lot, or whatnot comes like the EGTT trials. But in this sense, I think that these are the core concepts that we'll try to push over for the Andromeda. And this is the first step for personalizing resuscitation. Regarding the research now perspective, I don't know what's going to happen. Maybe new researchers will try to replicate our results using the same protocol or an adapted protocol. Let's see. I think that it's an open field.
Yeah, I think my opinion is that this reinforces the idea for many people of using CRT in common practice resuscitation in different contexts. It has been used more and more, etc., in cardiogenic shock, in de-escalation of fluids, fluid removal, in many things. And I think this reinforces this. I can't find many reasons to not use. I hope that this brings more use. And then we have demonstrated in these studies and in others that if you stop resuscitation a little bit and look and don't over resuscitate when you have a normal CRT, you can be confident that this is okay, but you have to still monitor, of course. This is one. The second one is that it is feasible to start thinking when you have an abnormal CRT, a septic shock patient with abnormal CRT, when you start resuscitation. And in this case, just look at the pulse pressure, not give fluids to all. This is what we do in general. The pulse pressure, it's a nice surrogate of stroke volume in general. So you have a low pulse pressure, is probably you are there. And in the beginning in the start of septic shock, probably it's not cardiac dysfunction, it's hypovolemia. So you go that way. And as you said, maybe it's nice to have, if you have profound vasoplasia, go try to adjust the norepinephrine. This you can do easily. This is what. So I think these things can be done, not all the form, the whole package, but to start with. And this would have benefits because remember what Eduardo said, that 2/3 of the patient resolved hypoperfusion or remain normal with the tier 1 intervention. So this is easy to do. And finally, we have 2 ongoing studies. One is the Andromeda-Pegasus, where we're looking from an epidemiological perspective. It's a cross-sectional study. In this now is 180 centers in 4 continents. It's a big number. We have now 1,500 patients where we assess in 2 weeks, every day, in new patient, the relationship between pulse pressure from the arterial line and stroke volume measured by a simple echo to try to understand but not in septic shock, only also in neuro, in postoperative, etc., to understand the confounders or the epidemiological determinants of this relationship, which is clear, is broad, but there are people that is more stronger, people do not, so that we can give information about 2,000 patients. We expect to publish this early next year, the Andromeda-Pegasus study, about the confounders, blah, 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 blah. And second, we are going to publish also at the beginning of next year, I hope, the Andromeda-Vexus study, where in 400 patients, we assessed Vexus, the congestion score, at 6 hours in both groups. And then we will see if there is a difference in congestion between the 2 groups. It's a ancillary subgroup study, but maybe it gives also a signal. And for people that are still, let's say, septic, I would strongly recommend a couple of articles. One is this very nice study in critical care by Daniel De Backer as the first author, a plea for personalization in septic shock, published in critical care, where all these concepts that we incorporated into Andromeda 2 are. And the other one, if they want to know more about CRT, is the paper we published this year in Annals of Intensive. It's the intricate relationship between capillary refill time and systemic hemodynamics. This paper is also, I say that to my residents that I love it. This is one of the best papers we have written because it contains physiology and also what you asked, Scott, about the relation between the MAP test and what the responses is discussed in depth. All the pathophysiological. It's a nice paper for people to start, to enter this.
I will put both of those in the show notes so people could check those out immediately. Wow. I can't thank you two enough. This has been incredibly elucidative and so enjoyable to speak to you two. Any final parting words?
Thank you for the opportunity for having this discussion. I think we are super happy to share our results, to share our perspective and how we envision both what the trial was designed, conducted, and showcased, and also what's the future for Hope septic shock resuscitation. And I think that having this discussion, analyzing the results, seeing the value of each of the signals is what makes it, let's say, more granular and beyond the abstract. So this is a wonderful opportunity.
This is my final words, is that to express gratitude to all the people that collaborated in these Andromeda projects. We just are building a more permanent network to do more studies in the future related to hemodynamics and perfusion, this relationship between these two worlds. And I'm very grateful for you, of course, for this opportunity. And I think from a personal point of view, I love physiology. I love old school physiology. And having had the opportunity to somehow bring these old physiological concepts to the bedside, it's fantastic because it's like with simple tools. When you look at an arterial line, you have so many signals of different things. And then and all this, for me, is fascinating. This is why I feel like, excited because physiology, back from the old text to the bedside, and with simple tools, when young people going to enter this world, they will never go back because it's fascinating, So thank you so much.
No, thank you. You're preaching to the choir. I love physiology as well, and that's one of the reasons I really love this study. So thank you both for doing what you're doing. Keep publishing, and I can't thank you enough.